Hi, my name is Dr. Hans. In 2000, I received my MD and started on a path of internal medicine and infectious diseases. In 2017, I became a rare disease advocate when my son was diagnosed with SYNGAP1 syndrome. And in 2021, I joined industry to work on rare diseases as much as possible. And I love talking about rare diseases. And today I'm going to talk about the pediatric to adult care transition. So sorry, it's been a little while. Today's podcast is brought to you by norovirus and upper respiratory tract infection. If you have school-age children, you probably know what I'm talking about. If you don't, well, kudos to you. Maybe you are using a handkerchief to touch your face. Maybe you've got people around you that cover their cough. I'm not that diligent or that lucky. So this topic was recommended by Madeline. Thank you very much, because my little guy is 9 years old and it's not on my radar right now. It's another 7-8 years away that we begin our plan to go from pediatric care, both general and subspecialty, to adult care. And what I mean by this is doctors have what's called a scope of practice, right? So for me, it was 18 and above, infectious diseases, bacterial, fungal, you name it, and no major procedures. Excuse me. I could certainly do minor stuff, skin biopsy, lumbar puncture, but we're not talking about abdominal surgery here. And at a certain point, a pediatrician has to pass off that patient to someone whose scope of practice includes adults. And when I think back to medical training, this was particularly memorable in two examples: cystic fibrosis and congenital heart disease. You know, pediatricians have what we call a high level of ownership of their patients, a sense of ownership. They've taken care of the kiddo from potentially birth, young age onward. And for the two diseases I mentioned, significant advancements in medical care, surgical technique have allowed those kids to live into adulthood. So, you know, I can think back to shadowing a pediatric pulmonologist, and there's the, 5-year-old playing with toys in the waiting room, and there's an 8-year-old flipping through highlights and scribbling through the games in there. And then there's a 27-year-old sort of sticking out, right? And it's a patient with cystic fibrosis. The pediatric pulmonologist had taken care of that patient since they were little, right? Little. And at the time, and this is 25 years ago, maybe they had a sense of hesitancy that passing the patient off to an adult pulmonologist just wasn't in their patient's best interest at that time. It's understandable. You worry about that. And for the congenital heart disease patient, it was similar, right? That they had improved surgical techniques to the point that these were kids with significant surgeries and wound up living into their adult years. And an adult cardiologist just wouldn't be necessarily familiar with the nuances of congenital heart disease. So when I started to put together some thoughts on the topic, I counted on my own experiences. And then I said, let me look online. And I was really pleasantly surprised to see all the guidelines and resources. So I want to bring these to your attention. There's this one, which is fantastic, from the Boston Children's Hospital. They put together a teen advisory committee to try to stoke that sense of independence, of ownership and initiative, and go through recommendations here about the transition from pediatric to adult care. And this is really well worth going through, getting organized here, everyone's role, etc. So I would really recommend you take a look at that. Then there's also this sort of shorter page from St. Jude's Children's Research Hospital also emphasizing it. So you get two different voices on the pediatric to adult care transition. What I would say is the easiest analogy is to think of it as almost like a relay race where you're going to be passing the baton, right? You've got to identify the person receiving the patient. And there you have to work with the pediatrician and say the who, what, where that needs to happen. And a phrase that I would encourage you to learn and use is, I don't want to be let down, right? Please help me. Who would you go to? Who do you think is best for my loved one? I just don't want to be let down. It addresses the idea that the pediatrician, the doctor in general, has an obligation to you. And it's not as maybe irritating as, you have to make sure that this goes right. No, we're going to work together, right? But not me by myself, because I'm the patient, right? I need a little bit of professional assistance, and I don't want to be let down. So hopefully put a little bit of guilt, onus on them to help you. And the idea that, when would you like to see this happen? Is if your scope of practice is up till 21, okay, we've got some time, or, we're going to plan around that. If it's a little bit older, so be it. Who would they recommend? Ask around, talk to friends, family in the area, others who have that illness or have complex kiddos, right? Of course, you have to triple check that insurance accepts that provider. Who's going to get the records from pediatrician to adult doctor? The fact is that in my practice, it really only came up once, and I was in the same building, right? Sort of in an academic setting, just on a different floor. And when we had that patient transition their care, and this was for HIV infection, I attended the appointment. It's really not hard, right? Take the elevator up, meet them there at a certain time, and say, hey, I'm going to be your adult care doctor. I've already spoken to your pediatrician. We're on the same page. This is how you reach me, etc. And the idea of the logistics being very clear. So maybe you want to have a visit to the clinic beforehand, talk to the office manager, say, what's it like? A doctor is judged on being available, able, and affable, right? So are they available? Are they just in clinic 2 days a week? That could be a problem, right? And in some academic practices, doctors have active labs, administrative responsibilities. They're not going to be as available. Is that what you want? Just think about it. Able, very key. Do they have maybe a background in this disease? Do they have familiarity with it? Do they convey or have a sense of confidence in managing your loved one? And then lastly, affable. And this is probably the lowest on my priority list, but it may be higher for yours. I can deal with someone who acts like Dr. House, right? I can go toe-to-toe with another doctor. That's fine, tactfully. You may want someone who's got more of a warm bedside manner, right? And I wouldn't judge a doctor after one meeting. It's just one snapshot, right? Develop a rapport with them. And then ask yourself after 6 months, maybe up to a year, is this a good fit, or do we need to find a replacement? There's also the issue of telemedicine and the idea that maybe you don't have a wide selection locally. Are you willing to put in the time, money, and effort to travel? So let's say to go to a what we would call a tertiary medical center, one that's got sophisticated resources for that first appointment, and then transition to telemedicine for follow-up at 3 months, 6 months, whatever it might be. The fact is, we have a local pediatrician right now, and we've got specialty care that's a drive. That works for us. We can get in for the sore throat, fever, etc. But if we need, specialty care, we're willing to travel for it or use a telemedicine appointment. So make sure that this happens early enough that you are prepared, right? That all the ducks are lined up and that first appointment goes well. And that passing of the baton happens. And then, like I mentioned a moment ago, that you've got 6 months up to a year, seeing if you like who's received and taken on the care of your loved one. No matter what, even if it doesn't work out, it's worth being appreciative and suggesting, let's say, not demanding ways to improve the experience that you've had. Is it possible to reduce the interval that we see you, right? Every 6 months doesn't really work. Can we move it to 3 months, 2 months, whatever it might be? It's really challenging to get everything across in a 20-minute appointment. Can we extend it? And this is something that I specifically have used in the clinic when I know I've got a person whose problem list is long, right? And it's going to take a while. Administrators don't really enjoy doing that, but if a doctor needs 30 minutes or 40 minutes, so be it. See if you can advocate for that. You might say, gosh, is there an easier way? And I will tell you that it comes down to money. You can find a practice that has a concierge care model, right? These are docs that accept patients with a retainer fee to start off, usually in the thousands, I think. I haven't looked into it. And supposedly make themselves more available. That they argue that this model allows them to practice medicine the way they want to practice medicine. So be it. It's not something I agree with, but you may find that is, just pragmatically speaking, the best way to get the care you need. Secondly, there's also the idea of donating. The fact is that this was a scandal reported in the New York Times where, you got the flash pass through the emergency room if you were a donor. And it doesn't surprise me. I didn't really practice in any situation where, high net worth individuals got specialized care. I did have to do a in-office visit, as in their office, not mine. So that bent the rules, and it was actually outside of, I think, our office hours. So I felt obligated somewhat to do that. It's only so many times you can say, when are you going to show up to your appointment? Before you have to bring the mountain to Moses. Anyhow, there's also research money. Maybe you can direct research funds and talk to the Office of Institutional Advancement and maybe get your own flash pass that way. But it's sad to say, but that's what it could take, or that's what it takes nowadays to get special care. Lastly, there was a second request in the message from Madeline, and that was, can you send 100 highly qualified doctors to our geographic area? And this has been a problem for quite some time, right? It's obvious that people are choosing where they retire, where they live based on medical care. And when I was putting together my thoughts on this, podcast, it was timely that this was in AARP magazine, a really good article by Dr. Zucker here in terms of optimizing your medical care in today's landscape. There's also the idea that I think it was January, maybe it was February, the former CDC head, Dr. Walensky, and a co-author talked about the challenges to the physician workforce. And this is really serious. Practicing American medicine is a challenge, and I'll leave it at that. And, there are states that don't even have a medical school. They haven't increased the number of trainees graduating from medical school in quite some time. And we've talked about it for 20, 25 years. So it's disappointing. But hopefully the telemedicine component can make it a little bit easier for you. The fact is that if you plan ahead, the transition will go well. If your pediatrician is involved, it'll go better. And if you talk to others about who is a great doc at the adult level, and if you can get in there by hook or by crook, it's going to go well for your loved one. So I hope this was helpful. If you have recommendations, please send them my way. And I'll try not to be delayed in the next podcast, which means avoiding getting sick. Thanks very much. Bye.